I would like to welcome our chairpersons, Dr. V. Rajendran sir and Dr. Chelvraj sir, and we have a most eminent speaker, Dr. Arulhaj sir, and I would like our chairpersons to honor the speaker. Dr. Rajendran sir will be presenting the shawl, will honor the speaker with a shawl. Dr. Chelvraj sir will present the memento to the speaker.
Good morning to all of you. At the outset, my sincere appreciations to DAISICON team led by Shanmugam for doing an excellent scientific agenda to the delegates. And thanks for the honor given to me by inviting and offering this topic to me. Now the topic that I am going to discuss today is what precipitates cardiovascular disease in diabetes very often. We all know that diabetes is a vascular disease. For about 40 years I am saying the same sentence which was done by Professor Sam G.P. Moses, my mentor. Diabetes is a two-in-one disease, metabolic cum vascular. There are many concepts. Right from the retina to the legs, the arterial system is affected. But we are always much worried about cardiovascular system because that causes, now we listen from Dr. Mahadevan about the heart failure because the common endpoint in diabetes is due to a cardiovascular disease. And there are many causes, we know that, but I would like to focus on postprandial hyperglycemia, which we call it as a PPG flash, that causes, a cardiovascular disease. How it is causing it, some evidences for that, some systems for that. First of all, what is postprandial or post-meal hyperglycemia? ADA says after OGTT it is 140, and our IDF says post-meal hyperglycemia is 140. Type 2 diabetes, all of us know, is associated with atherosclerotic heart disease very much. And postprandial hyperglycemia or high blood sugar levels in the meals is an independent, continuous risk factor for cardiovascular disease. And why we are focusing on that is controlling this postprandial hyperglycemia can reduce the incidence of cardiovascular disease. Because we are already bothered only about cardiovascular disease. How we will see that? This is how, our meal is when we take the meal, how the blood sugar is being controlled. One side, glucagon comes, another side insulin comes, and they balance and they try to maintain the blood sugar normally. These are the evidences that are available in the literature. Supporting the postprandial hyperglycemia leading on to cardiovascular disease. Any number of evidences are available here, nearly about 20 I have listed here. And there are evidences, as I said, the PPG is a better predictor than our HbA1c. Control of blood sugar, we always focus on, HbA1c. But when we want to focus on cardiovascular disease, we will have to go for a postprandial hyperglycemia. There are many number of studies which I will go into it. And this is a meta-analysis of the postprandial hyperglycemia and CAD. Nearly about 12 studies have been said there is a direct link between the postprandial hyperglycemia and a cardiovascular disease. And then the spikes, as I said, the PPG spikes increase. How it causes? Now we have seen PPG causes, some evidences. Now the mechanisms. PPG increases the oxidative stress. Postprandial glucose levels are better prediction of CVD, as I said. Another important point is here is we are talking about diabetic. But even in people who are not diabetics or pre-diabetics or IGT, a postprandial hyperglycemia or a spike always precipitates an early coronary artery disease. This is the pathophysiology of CVD associated with PPG. That is PPG, it results in AGE, advanced glycation end products activation, PKC activation, platelets and coagulation system, nitric oxide and PPR activation leading on to endothelial dysfunction and a plaque is being formed. these advanced glycation end products, there are any number of products like pentosidine, and all of them, what they cause, they do a vascular remodeling. A vascular remodeling leads to an arterial stiffness, which may increase the cardiovascular risk. The second component which is involved in the mechanism is methyl glyoxal. We call it a MGO, which is a byproduct of glycolysis. Prevention of this MGO and AGE accumulation can reduce the incidence of coronary artery disease. Among the cells, two cells are much sensitive to PPG. One is our own neutrophils, and which go on to stimulate the thrombopoietin and produces endothelial dysfunction. And secondly, a PPG leads on to excessive oxidative stress. Hyperglycemia induces an overproduction of superoxide anions, which we know it is an endothelial dysfunction agent. Ultimately, all of them end in a endothelial dysfunction with NO, ENOS, and presence of endothelial dysfunction serves as an early marker for vascular failure. A flow-mediated vasodilatation. Flow-mediated vasodilatation. When there is hyperglycemia, the vasodilatation comes down. Thereby, it leads on to an entity called as vascular failure. This is a new terminology here. The early stage is endothelial dysfunction. Vascular failure is the end stage wherein there is a atherosclerotic heart failure. And this is the system that goes in. There are all the risk factors, go for an inflammation or metabolic abnormality, endothelial dysfunction, goes for smooth muscle proliferation and stiffness of the vessel, plaque instability, calcification, and ultimately end in vascular disease. To summarize, an atherosclerotic cardiovascular disease, all risk factors come in, right from diabetes, smoking, hypertension, dyslipidemia, obesity, go for an oxidative stress, goes for an endothelial dysfunction, which is due to all these factors, ultimately ends up in progresses of the atherosclerosis. Inflammation, as all of us know, is a part and part of it. As I said, the leukocytes and the T lymphocytes are the two cells they are picked up. There are a lot of adhesions molecules, like ICAM and VCAM that can also be of use, and it can be well studied when these markers are increased. Endothelial dysfunction is very much enhanced here. A superoxide overproduction, that leads to endothelial dysfunctions, and in diabetic blood vessels it's very, very common. Now again there is a glucose spike, postprandial spike, leads on to inflammation, oxidative stress, endothelial dysfunction, and cardiovascular events. This is what has been summarized here. Now this endothelial dysfunction, as I said, due to postprandial hyperglycemia, all the mechanisms discussed have been summarized here, and there are many studies supporting that. There's a Hoon study from Netherlands which says that a postprandial hyperglycemia increases the incidence of cardiovascular disease. A Hoon study has already confirmed it. There was a this way, that way effect in the Finnish study. Again, Honolulu study says that there is a linear link between postprandial hyperglycemia and CVD. And conclusion of this study is increasing the risk gradient existing between the postprandial glucose as well as subsequent CHT. And postprandial blood sugar and HbA1c, as I said, overall control HbA1c is more useful. Now TIR has come. But for the coronary artery disease, you should focus on postprandial hyperglycemia. There are any number of studies available here. And insulin resistance is one. We all know when there is a hyperglycemia not under control, we always exhibit insulin. But insulin has some, this way, that way effect. That is, it controls the blood sugar but causes hypoglycemia. When there is a tight control of blood sugar, hypoglycemia is being precipitated. A hypoglycemia has more cardiovascular issues than a hyperglycemia. This is a PPG reduction. Now we said that PPG causes CVD, how it causes evidences. Now how to control a few things I will try to share with you all. The post-OGTT glucose levels are very importantly associated with CVD, agreed. The glyburide and ripaglinide that reduces the postprandial hyperglycemia. promote regressions of carotid thickness. This has been proved. This is the way it goes there, your blood sugar as well as the vascular level. The drugs based on the CVD, this is the way we can try to classify it, like DP4 inhibitor, this amylin analogs, GLP, and then we try to structure it depending on the about the postprandial glycemia. Which tissues are highly sensitive to high glucose levels? As I said, the bone marrow progenitor cells and the WBCs are very, very important. This is about the postprandial blood sugar that I told you. Without hypoglycemia, we should be able to do that. These are the group of drugs that we are using it, like agarbose, miclitol, and then SGLT inhibitor, GLP-1 agonist. I'll just quickly specify. Now, the sodium glucose transporters, we all know SGLT inhibitors, that the blood sugar level reduction is not very much. But the postprandial hyperglycemia is touched very well by it, though it can cause a normoglycemic ketoacidosis. GLP-1 agonists are very good at controlling the postprandial glucose level. All these trials, this liraglutide and xenite trials are very, very informative here. Ripoglanide, as I told you, it prevents the intimal medial thickness and it causes a regression of atherosclerotic. This has been very well compared study with the miclitol and metiglidine, that postprandial blood glucose when it is reduces, and it reduces the atherosclerotic aspect of it. There are designer cytokines like IC7FC, and it has been found to improve the glucose tolerance and the postprandial hypoglycemia. Alpha glucosidase inhibitors, very rarely we use it. We use it as a combination only. But postprandial hyperglycemia, a single dose, it can reduce it very well. As all of us know, it prevents absorption of carbohydrates from the intestine. Therefore, the postprandial rise is very well controlled. We can always try that. And this agarbose also, studies are available proving for it. Another important drug is thiazolidine. Though it has got some side effects of edema and precipitation of cardiac failure and renal, but a postprandial hyperglycemia control, it has been very well marked, and it reduces the inflammation in the vessels in diabetes, because highly sensitive CRP has been found to be reduced, which is very high. And this is very good, and it can reduce the hyperglycemia as well as the incidence of coronary artery disease. Coming to the insulin, as I said, we should avoid a hypoglycemia effect here. Some of the newer insulins, we can definitely use it as a postprandial used to reduce the hyperglycemia. A combination is also very useful. See, in this, if you all see that metformin, which is the first drug, it's not coming here at all. It's not coming. It can come only in the combination types. When you want to focus on postprandial hyperglycemia, only metformin will not help. And agarbose, thiazolidine, or GLP, all those things have to be combined, and so that we reduce the postprandial glycemia and reduce the incidence of cardiovascular disease. Ladies and gentlemen, I have shared you some thoughts about the value of PPG in CVD and how to reduce it, and what drugs can be used. Postprandial high glucose spikes as opposed to high average glucose levels is the key determinant of CVD. A glucose lowering strategy should be directed against reduction of PPG spike. Hyperglycemia even impairs the resolution of lesions in setting of the cholesterol lowering. Postprandial hyperglycemia should be considered, my suggestion. It's not only my suggestion, it is recorded also, that it should be included as one of the cardiovascular risk factors, similar to hypertension, hyperlipidemia, smoking. It should be monitored and treated. Thank you very much for the opportunity here. Any inputs, I would love to listen and add up here.
Thank you very much, Dr. Arulraj, for your lucid lecture on postprandial hyperglycemia and cardiovascular risk. The DECODE study 1999 and the Indo-Pacific 99, again the diabetic intervention program 96. These were the people first, they proved the relation between the postprandial hyperglycemia and the cardiovascular risk. Three main mechanisms: oxidative stress, inflammation, and endothelial dysfunction. By reducing postprandial hyperglycemia, you can reduce all these things and improve the vascular function. The one thing I want to add, the post-lunch hyperglycemia is an independent risk factor for cardiovascular risk than any other parameter, either fasting or HbA1c or any other parameter. And bolus insulin definitely reduce the postprandial hyperglycemia, which is the final weapon for reducing postprandial hyperglycemia. Intensive insulin reduction, blood sugar by insulin reduction, followed for 10 years, proved that reduction of postprandial hyperglycemia reduces the cardiovascular risk.
The floor is open for discussion. Questions from the audience?
This insulin resistance, hyperinsulinemia is a basic of postprandial hyperglycemia, and insulin resistance is a cause for many of the macrovascular diseases. Just I want to know, is there any HOMO model testing has been done, those for the increased incidence of CVD in diabetes?
There are any number of studies available, sir. I have given about 14 studies that a postprandial even that area I have a small, difference here. Only insulin resistant need not cause postprandial hyperglycemia. The absorption and the deficiency of insulin and insulin resistance can cause it, number one. Number two, all these factors have been the end result of scientific studies, sir, which have enlisted.
Sir,
Yes.
thank you for taking us through all the data. Two questions. One, your thoughts on the 1 hour postprandial. There has been evolving concept on that, though not very validated. So your thoughts on the same. And non-pharmacological means of reducing the postprandial spikes, be it fiber, proteins, pre-meal exercise, post-meal exercise. Your thoughts on both these aspects?
See, that has been definitely proved, sir. Now everywhere, I was really enjoying the non-pharmacological therapy of heart failure. Though we say that he has put it under a separate category now, which is becoming a very popular, as all of us know. Even that has been proved to reduce the postprandial hyperglycemia, and thereby it is reducing the incidence. I have not fully gone into the management of the PPG. I have only tried to prove that PPG causes this, and this is the drugs that we are commonly using is different types, whereas when we use it, we should focus on a drug that can reduce the PPG also, sir. But non-pharmacologically definitely valid, sir. Thanks for your reminder.
So the 1 hour thing, the 1 hour PP, your thoughts on 1 hour postprandial?
See, usually we do a study, OGTT, we have it. Whereas when for a scientific program, we always have it for 2 hours, sir. Yeah, that's what I said, OGT. Diagnose, OGTT 1 hour. Yes. This is an often debated, it will continue to be debated, sir.
Sir, actually 1 hour PPG, if you target with the high dose of medicine, whether insulin or OHS like repaglinide or whatever it is, if you increase the dosage, definitely the patient will go for pre-lunch hypoglycemia.
Pre-lunch hypoglycemia.
So
yeah.
2 hours we have.
I agree that.
Even
2 hours is better.
Even 1.5 hours if you target some.
Yeah, 1.5
people,
hours
they are
is
going-
also being targeted, sir. I agree with you.
So 2 hours is most ideal in our set of patients. And as you rightly said, that medical nutrition therapy is also very, very important because after seeing this CGM patches, we get a lot of inputs from patients themselves. Sir, idli is increasing sugar level, dosa is reducing because glycemic index of idli is like that. So tomorrow we will have detailed discussion on medical nutrition therapy. We can discuss that.
Thank you very much. Any further learnings? So, okay, thank you, Chairperson.
Excellent presentation by Professor Dr. Arul Raj. Again, emphasizing the concept that postprandial hyperglycemia is one of the important risk factors for cardiovascular events. Thank you, sir. Thank you. But I think your favorite topic of lifestyle modification with diet and exercise, maybe you are expecting that you will be talking about that diet aspect a little for postprandial hyperglycemia management. Thank you, sir.